And I found out that the best thing to do is record each question individually rather than having a long one. So
Okay.
you're here first, so let's go with your
So
question.
my question is, in my journey, I was diagnosed with fibromyalgia. I have some overlap in ME/CFS,
Absolutely.
but there was an aha moment
Hmm.
where I had a rash in November, and then I took cetirizine, so Reactin,
Hmm.
and
Hmm.
then brain fog lifted by 75%. Brain fog that had been there for months, and I had mental clarity. So within 90 minutes, it was boom. So that was a big haha clue moment. So meaning that there is an histamine issue because I'm clinically responding. So I have no GI symptoms, no respiratory symptoms, no dermatological symptoms, but there is this question about MCAS underlying
Absolutely.
that it's not
Man, Nicholas, you're
answered.
so good. Because I know you're a nurse, right? By training.
Yeah.
Yeah, absolutely. Absolutely. I see MCAS all the time, especially after COVID. I think I really do think that COVID has changed people's brain and our immunology,
Mhm.
neuroimmunology, and even our neurology. And so, what you experience is a typical brain fog caused by, and there are multiple ways to cause brain fog, but that mechanism is by histamine. And we know that because when you took antihistamine, it got better.
Yep.
So that's really great because one of the tools that I use for MCAS is ketotifen that has been compounded.
Yeah.
And ketotifen does two things, which is first is anti histamine, but the second is more important, which is the um, stabilizing of mast cell. Cromolyn sodium is supposed to do it. I think ketotifen is much more effective in
Mhm.
doing it.
So that was pretty much my question. I feel like I'm narrowing down, and I don't want. I already have pill fatigue, and I'm trying to be really precise and surgical. So I got prescribed yesterday ketotifen. Um,
Excellent. Good job.
I since I don't have GI symptoms, I didn't feel like Prominent was relevant.
No.
I'm a bit concerned about side effects, of course, because everything I've been introducing has
What's the
been.
dose they gave you?
I think it's 1 milligram.
Okay, that's it's a fair dose. I think people know how they're gonna react because if they take like Benadryl or H1, and some people say, "Hey, if I just smell that stuff, it puts me out
Mhm.
for half day, and next day, another half day, I'm out."
Yeah.
Then those people may be lower dose, but if you don't have those issue, I think the standard dose is not going to hurt you
Mhm.
probably.
So I'm on LDN break for 12 days because I had autonomic crash going from point 0.25 to point 0.5, and
Yeah,
now I have.
I read that. Thank you for sharing. That's what I was thinking. That very, very knowing a little bit about you, I thought very ambitious plan.
I was pretty steady at point 0.25, so I feel like I'm probably my right dose is probably just under point 0.25. I'm gonna
Mhm.
restart at point 1. I'm
Okay, that's
waiting
a
for
good idea.
I'm waiting for the new
Mhm,
concentration because now I
mhm,
need zero point 0.5 milligram per ml. I'm gonna
mhm,
titrate slowly,
mhm,
but I'm wondering if I should reintroduce LDN, have 14 days of clinical silence, and
mhm,
then maybe introduce ketotifen. So sort of the how I should go about it, because I have the clues about this MCAS. At least I have the joint pain. Like I said, I have the histamine um,
mhm,
confirmation by H1
mhm,
antagonist.
mhm.
So that's a bit how I just crashed, and I I don't want to crash again. I want to make sure that I improve.
Yeah.
So do you have any?
So usually I say one dragon at a time.
Yeah.
One dragon at a time, meaning one problem at a time. I think that's probably the best way to start stop. And I think it sounds like you are zeroing in on your sweet dose or tolerable dose at this time, which
Yeah.
will change with time. But I think a lot of times time is the difficult part, and the second is to understand engaging one dragon at a time actually
Mm.
is advantageous to people. And the more severe condition is, I think the more you have to be gentle and
Mhm.
understand that you're walking on a thin ice, especially people with post-exertional malaise or equivalent of it by endorphin depletion syndrome. I think that it's very injurious to morale
Mhm.
when you go through it. It's like some people almost like I'll never get better, and that's such a sad. So I think that's my role with my patients is to kind of guide them, and it's kind of hard because when I go light speed and I tell them that no, go slow, go gentle, one thing at a time, and then otherwise they I get fired because like you're going too slow. You just want to take go.
Mhm.
And it's like, well, I want to be safe, and I have to practice medicine the way I feel safe. Nicholas, I enjoy your post. I enjoy your questions. You're a deep thinker, Nicholas. What kind of nurse were you, if I don't mind
I was
asking?
ER nurse. I was worked in northern Canada in remote indigenous communities. I worked with NGOs abroad with the Red Cross. So I did a bunch of things. I studied tropical medicine in Belgium. So I had a nice run there. But COVID, like many of nurses, I got out after COVID. I was burnt out, and that was it. I have two more questions for you. One is about my endorphin level, according to your scale, was pretty nice, but now I'm
Mm-hmm.
seeing the MCAS sort of link,
Hmm.
which might have
Hmm.
been why I crashed at such a low dose. So that's an
Hmm.
hypothesis.
Hmm.
But my second one, this is more a question, is
Hmm.
what do you think about doxepine? Since sleep is a big issue, and doxepine is not much utilized by doctors, but it does stage at low dose. It
Yeah, doxepin is good. I used to give amitriptyline, but one of the patient yelled at, not patient, but members said they tried it and it was really terrible because it made them gain weight. So I think that the like if you're taking a small dose of tricyclic antidepressant, I used to even compound it so that they wouldn't get side effect,
Yeah,
and
it's at,
it
at
worked
3
well.
milligram, it only acts at
Exactly.
stage 1.
Yeah.
And for insomnia,
Mhm.
because my concern is I cannot touch
Mhm.
anything with serotonin, so I'm looking for a way
Mhm.
to sleep, and DORAs haven't worked, so I need an option.
Mhm.
And I
So
was wondering.
doxepin, I think is okay. I use trazodone, but I think that it's really sleep is individual. And the other thing I usually tell people is that if you try to use something for every day, it'll surely fail. Try to get 1 to 2 nights sleep using one agent, and then 1 to 2 nights using another agent, and then 1 to 2 for another agent. That way, you get 6 days of decent sleep without becoming dependent. Obviously, I say do it is you bracket it. You say maybe Monday, Wednesday I use this tool. Maybe Tuesday, Saturday I'll use this tool, and maybe Thursday, Friday, or Thursday, Sunday I'll use this tool, and then Friday I will be medicine free.
Mhm.
So I think that your approach is excellent, Nicholas. That's why I can tell that you are a professional and you're highly intelligent and you kind of get bored easily because you master it and then you want to learn other things. You have curiosity. So I
So
think the world needs you back as a healer.
so yeah, I like that, and the thing is, I feel like if I don't get some nice, decent, consistent sleep, it's gonna be harder for
Impossible.
For LDN to
Impossible.
to
Impossible. Sleep is so critical. I mean, that's why when I just sent, I posted the this was from I think yesterday, and we talked about this person was taking LDN, fatigue got better, and then it stopped getting better, and why? And it wasn't dose related. So what I said is that it's not just one thing that causes chronic fatigue syndrome, and you have to understand chronic fatigue syndrome is diagnosis of exclusion. That means you have to look at everything. So there's a list of things that people ask people to look through, which is sleep, hormone, hidden infections, nutritional deficiencies, endocrine dysfunction, and autoimmune diseases.
yeah.
And long COVID, by definition, is a autoimmune disease. By definition, it can cause severe endocrine dysfunction, especially with cortisol. But it also messes up serotonin, norepinephrine, and sometimes dopamine. And then people behave as if they're all the neurotransmitters are blocked,
Mm,
and then they have severe depression symptoms. I think coming from severe endorphin depletion,
yeah.
and because when people have endorphin, what do you call, depletion, I think that they don't need much more to get in trouble. And once they get in trouble, they need time. And I used to say 1 week, but some people 1 week is not enough. And related to that, and that's why some people don't even tolerate 1 microgram. You have to go to nanogram dose. I
Mm,
think people are getting weaker and the diseases are getting stronger. It's not the best combination for us. So we took about 10 minutes. I know Jill is our moderator, and she probably does not have questions, but I think Beatrice got here.
Hello, hello,
Hello, Jill. Do you have question
hello.
again?
I am here.
Yeah, I know you're here, but do you have question?
No, I'm just here to listen. Actually,
Oh, that's what I thought.
I just wanted to say, actually, I'm doing a bit better with
Oh,
methylene blue.
that's really great.
I find methylene blue. I've gone up to 20 drops a day. Not every day. I'm taking it about 4 times a week, and I'm gradually noticing that I'm doing a bit better. And which I'm really pleased about, because I felt a bit stuck and I thought I need to try something different. And I find I feel more alert. I've had a cold this week, so I have been tired. But this morning I was doing some spring cleaning. You know, uh, I was hoovering. I haven't done that for a long time.
Yeah, methylene blue is really amazing because it doesn't matter why you have whatever condition, you get relief. Because the thing is that first part is mitochondria regeneration, and then as you go up, it begins to address hidden infections. The hidden infections
Right. Yeah.
that can make a huge difference. So I'm so glad that's been like, and that's been my secret weapon for long COVID and chronic fatigue patients because, and what I call methylene blue is poor man's IV vitamin C. And what I mean by
Oh,
that is
right. Okay. Yeah.
IV vitamin C will kill whatever is not supposed to be there. It lowers inflammation, and but you do have to check G6PD because it puts a pro-oxidant pressure on the body system. And we're bigger than the microbes, so we can take more than that. But there's some limits, especially if they have G6PD deficiency. Guess what? Another condition you have to check G6PD deficiency is methylene blue. So
Right.
usually
Okay.
methylene blue, they recommend it. I've never seen anyone. I've not even found anyone. And I've asked and researched, can anyone get in trouble with oral methylene blue? And
Yeah.
I couldn't find even one thing. But of course, the people scared to death because everyone's talking about serotonin syndrome, and the
Yes, that's
reason
right.
is
Yeah.
because methylene blue also supercharges your serotonin system, which is really fantastic for as long as they're not taking SSRI medication.
Mhm.
It
Yeah, I'm
it
not.
activates the energy from mitochondria side, but it also activates energy from serotonin side. And when you strengthen serotonin, that's one of the best ways to strengthen your melatonin is having a strong serotonin. So then it'll help you with sleep. That's why I love things like LDN and methylene blue. That it's just one thing, but it's capable of doing multiple things,
Oh,
which
I'm
means that
sleeping. I sleep so well. I'm sleeping so well at the moment as well. I
yeah.
feel that I'm getting really refreshing sleep.
Yeah, and
Um,
then that is a combination of LDN, which um, after COVID it has changed because after COVID I found out that LDN seems to cause insomnia. But before COVID,
yeah,
I didn't see that a lot, and after COVID, I saw it. So now it really depends. But LDN can strengthen sleep architecture by giving you better REM sleep, less interruption, which means that when you get up, you feel more refreshed or you need less sleep. And then serotonin systems like methylene blue can do a lot. And taking 2 days off, I think, is very wise. 2 to 3 days off is wise. I myself take 20 to 30 drops every day, and
oh,
then
do you?
I take
Yeah,
I take like 2 days off. So, and
yeah.
Yeah, I can tell because if you're on 20 drops to 30 drops of methylene blue and 0.5 milligrams per drop, your pee turns blue. So on the
Yes,
off day,
that's right.
you cannot notice.
Yeah,
It's like, oh,
yeah.
I'm clearing methylene blue, and then when you start taking it again, then you get that. So
That's right.
I'm
If you have a little break and then you really feel it. And
and
I was a bit nervous of it at first because
of
I
course,
read a lot and I thought, oh, is it going to be dangerous? Should I? I just started off with a few, 4 or 5 drops,
yeah,
and then I've gradually increased it. And I think at this level, 20
mm,
drops a day, I can feel it.
yeah.
I can feel, and just taking it 3 or 4 times a day. And I think, yeah, this is actually, I feel that, after say 2 or 3 weeks and gradually, I think this is something's making a difference. It's got to be the methylene blue
It
because
is.
I'm not doing anything else different.
Because even with long COVID patients that this the thing that I find is that people who are determined will get better faster than people who are not determined, and the people who are systematic, they tend to get better faster because even they make a mistake, they can go track it back and say, oh, this was a problem, and then they can fix it. So the way the strength of the way you're doing it, the system by system, is that if we look at it doesn't fix the nutrition, endocrine system. I think that LDN is better, autoimmune LDN is better, but hidden infection and mitochondria, it does help. And if people have any kind of autoimmune thyroiditis, then hormone will get better. And then cortisol wise, I'm unsure, but I think methylene blue must help with metabolism of cortisol to break down cortisol faster. That's just and then my sleep quality is better on methylene blue, even though I'm not sleeping as much. So it's been really amazing. And on the patients that I noticed get better faster are a healthcare providers who want to go back to what they do because they love it, right? Not
Yeah,
people
of course. Yeah.
who and those people tend to do better. And even with those people, the methylene blue has been. I always start with LDN. It's a cornerstone,
Yeah. Yeah.
yeah, of the treatment. I know Beatrice has been here for a while, and I think she was second to arrive. Sorry, we skipped you, Beatrice. But I think you're going to ask me about tendinitis, right?
Oh yes, I'm wondering about that.
Yeah.
I've been having a hard time.
So
Do you hear me?
tendinitis,
Yeah.
and we do know that if people eat a medication called fluoroquinolones, which is antibiotic like Cipro and other medications, that it we know that it harms the tendon, or we know that it's a poison to tendon. We know that it can rupture the tendons, and we knew that because it does that in beagle puppies, who they tested on. Quite cruel, but that's what we do. And for the longest times, the doctors used to joke that it happens with beagle puppies, not people. But of course, with time, we
Hmm.
find out that it does it to human beings too. So the
Hmm.
question, can COVID and other viruses result in tendinitis? Absolutely. Is there excellent results of it? No, because we tend to see what we're looking for. We tend to see what we are looking for, and we weren't looking for that. So now we're looking for it. We're beginning to see it, but it's, I would say, observational at this point. And
Hmm.
then the other part is that if you have tendinitis, if tendon was inert and not joined by nerve, how do you know it hurts? What's hurting really? It's your nerve
Um,
that's hurting.
hmm.
So there
Hmm.
are two issues.
Something.
One
Yeah.
is the ripping of the tendon. The second is the pain signal that comes from ripping of the tendon. So those are two. And there are some people, they like in the knee, they say something popped, or something ripped kind of sensation. So then there's no pain. So that, because some tendons or ligaments don't have a lot of innervation with nerves, but you do, it sounds
Hmm.
like. So I
Hmm.
think that LDN is reasonable, but like, I think you've heard me say that things tend to be um, necessary and sufficient, meaning that LDN is good enough. Or it's an LDN may be necessary but insufficient, needs something else. So,
Hmm.
for example, for chronic fatigue, LDN plus methylene blue seems to be helpful. And methylene blue, like I said, it addresses multiple things, mitochondrial issues, as well as hidden infection. And most of us are carrying hidden infection. Just don't know what it is. And to test it is several $100s. So a lot of the patients don't want, or they can't, or I mean, because having an illness that's chronic is very costly.
How do you test? I'm going to a pain. I mean, I've done this before, but I had the appointment, a pain clinic here where I am in Switzerland locally at a hospital because I had the appointment. I'm not sure I'm going to learn anything new that I haven't learned in the last 2 years about my pain, but my pain is just, I have some new things. So it's basically, those are all anesthesiologists. I doubt anyone will know about LDN, but I'm going to ask them.
Good for
But
you.
so when you're saying about the infection, like what testing would I ask a doctor for?
No, you just have to ask them. Listen, doctors aren't like cats, and herding cats is not really easy, and they get offended rather very easily. I don't know why. I don't mind when patients ask me questions. And Nicholas, who's a nurse, I think he's worked enough with enough nurses that we're not, we have, like, as a group, room for improvement for being open-minded and collaborative and shared decision making. So you just ask
Mm,
them, and then in the website, look, print the article that I written, and there are other articles like that. And that this one is about LDN and pain, and
mhm.
just print it and then give it to them and say, hey,
Right.
I found this, and this doctor writes a lot and publishes books, and this is one of the
Mhm.
articles. So you can talk to them, I think.
I
And
was
then
asking more about the I'm sorry to interrupt. I just don't want to because the call's gonna end soon. But anyway, but you were mentioning before about the hundreds of dollars or whatever money it takes to do tests for the hidden infection. Is that blood tests?
well, it's
Because
blood
I would
tests.
rather ask for that.
Yeah, but the issue with that is that for in the country of US and Canada, probably, and England, every test you do as a physician that's covered by insurance, the test code and the condition code has to match up. If the test code and condition code doesn't match up, it gets rejected. In the US, we do, and probably UK. I don't know about Canada, Canada too probably, but there's a way to get around it by paying cash. Switzerland, I don't know your
Hmm.
system, but
I would pay cash. I don't care.
yeah.
Yeah, you.
So
I
then
think
you
any
just
doctor will probably do some. Well, I'm not sure, but
yeah. Well,
I
tell us
know that in
about
the
it.
United States they will.
Yeah, tell us
You
about it. I just don't know other countries' system, so
right.
I'm not qualified to say anything.
Okay.
So
But
does it
you'd
answer your
ask
question
I
about
would ask for a
tendinitis?
test.
Yeah. Does it answer your question about tendinitis?
Yes, it does.
Yeah.
It does. I
Excellent.
just wish it would be nice to find someone who could speak to it
Well,
besides
yeah,
you.
yeah. So,
Okay.
Dolores, welcome.
Thank
Do you
you.
have any questions for us? And if you want to mute, it's in the middle of the screen, lower left side. There's a mic, and then if you hit it again, you will be unmuted. Right now, you're muted. Or you can type things too. It says you type someone, and is it side effect of being on
There.
too high
Now my
elevators?
mic's on.
Yeah,
My mic wasn't going
yeah, yeah,
on.
yeah. Go ahead. That's what I figured.
Yeah, I've changed several things lately, and I don't know. I'll put it camera here too. I don't know if it's the LDN that has caused my joint and muscle pain. My shoulder has been doing a lot of cracking and popping, and it really hurts. And I've been increasing my LDN, so I don't know if it's that. I've changed hormones, and what else was it? Actually, I had it written down, but it's in the kitchen. Let me. um, oh
So
yeah,
while you're
that,
walking, I'll say this.
but
We talked about earlier before you joined us the importance of making one change at a time so that you can attribute the effect to the change. When you have multiple things going on, I think it's very difficult to say. But from LDN perspective, I would say that if you blockade your own endorphin, then your perception of pain should be higher. Now you got your list. Now you can use your list.
Okay. Yeah, we altered my hormones a bit. And I've been doing methyl B12 injections and taking methyl supplements, and I was reading that could possibly cause joint issues. So I've switched from the methyl to the hydroxy, and it's only been a few injections that I switched, and I still have the joint pain. But a couple of days ago, I did lower my LDN. So I don't know.
Yeah,
Maybe.
and I don't know either, and no one will know until you decide to do one change at a time. It's
Yeah.
impossible. I think that in science we call that confounding variable. That means that multiple things are doing multiple things. So I'll give you an example of it. Long time ago, there was a study that showed that coffee drinkers are increased for heart disease. What they found out, actually, those days people smoked more, so coffee drinkers tended to be also smokers. So it was the smoking that increased the risk, not coffee. So that's
Yeah.
confounding. And the confounding means that you're engaging multiple dragons at one time, and then we're not sure what pissed off the dragon. So I would say I would highly recommend one change at a time. Lisa,
Okay.
welcome. We have a question. We have about 4 minutes before I'm going to close this out. Question.
Hi.
LDN.
I was just typing, so I will just
Yeah,
tell
yeah,
ask my
yeah,
question as
yeah.
it is. Hi.
Hello.
Question. I'm on the very low dose of LDN. It's
Yeah,
0.3 milligrams. I lowered the dose due to insomnia.
yeah. We were just talking about that earlier.
Yes, I've heard Nicholas talking, and I have quite similar problem with mast cell
Yeah,
activation syndrome.
yeah,
I'm very, very sensitive to everything.
yeah,
And the dose was zero point 0.6 taken in the morning, LDN in the morning, and I was doing quite well for months.
yeah.
And then insomnia started, although I'm taking it in the morning, right? So I lowered the dose to zero point 0.3, and
That's
still I'm
yeah.
a sleepless like maniac at night,
So
quote unquote.
what would be the next step? What would be the logical step if point 0.3 doesn't do it? I mean, usually I tell people if you're having side effects, stop it. Stop it, because the main thing is that some people have better endorphin reserve, but their ability to produce endorphin has been compromised. So at one dose that is considered low, zero point 0.6 in my practice is not low. That's medium dose. So that's and you take it, and then the mistake they do is they half the dose or they cut the dose by a little bit. But I think that in order for endorphin to recover, you have to stop and let it recover. And the speed of recovery, I think, is very different. And again, I'm not telling you what to do. This
No,
is what I
you're
do with
right.
my patients. To
You
my patients, if you have side effect, my standard thing is I just talk to them and say, "Hey, what do you want to do? Do you want to stop, or do you want to do you want
suffer.
what do you want to do? Do you want to skip the dose for 7 days? You want so they're
7 days,
different.
right?
Yeah,
I'll
different
try.
things. Well, that's what I tell my patients. Some people, but I like last time I had neuropathy. It it was really bad neuropathy, so I wanted recovery faster. So if I do the usual, it'll take me a month, 2 months to get there. So I took the therapeutic dose, which is I knew it would be too high for me. And then what happened is that a day or two, I feel like I'm going to just not, not be alive. Um, and then but I stopped it, so I'll take one dose. I know what's coming, it's going to be terrible, so I'll take it maybe Friday night, and then Saturday it's terrible, Sunday it's terrible, and Monday it's like, oh, I'm better now, so I go to work and then give myself a couple of days, and then I'll do it all over again. So instead of Friday, maybe take it Wednesday, and this time it's terrible, but it's not as bad, and then I'll recover again, challenge again. And the reason for that I did it is because for neuropathy, I found, at least for myself, that higher dose is needed. And if I titrate, So what the lesson is that don't get off the LDN.
Don't give up, right?
No,
I'm
no,
in your
do not get off. For me,
Do
don't
not
get off
give up.
the LDN. Since I have neuropathy, stay on a dose that I can quickly jump without side effect.
Yes,
So
I
it's 11
feel
o'clock. It's 11 o'clock. So I'm going to bid
sorry.
everyone
Thank you so much.
farewell.
And
Great weekend. And if you have further questions, just
Dr.
post
Kim,
it,
thank you. I'll post
and I'll
it.
do my
Thank you.
best to answer them. And then
I appreciate
I
it.
will.
Thank
Yeah.
you.
Thank you so much. Everyone, have a great day.
Bye bye. Thank you.
Thanks. Bye bye.
Thank you.
And let's do this.